Hi, I'm Dr. Mark Swartz from the Mount Sinai School of Medicine, and today I'm going to be demonstrating the complete examination of the man and the breast and the pelvic examination of the woman. The complete examination has many different components, most of which I will be demonstrating today. However, in actual practice, the physical examination is dictated or focused by the patient's history and the patient's chief complaint. Mr. Johnson, hi, I'm Dr. Swartz.
Hi, how are you?
How are you today?
Okay.
Good. Before we begin the examination, I'm just going to wash my hands, okay? Are you comfortable?
Yeah, I'm fine.
Okay, great. The first part of the examination involves blood pressure determination. Blood pressure determination is a very important part of the physical examination. It's very important, however, that you use the proper size cuff for the patient. If one were to use a large cuff for a person's arm which might be small, you would erroneously record a high blood pressure. And the converse is also true. This is a standard adult cuff. And this is the type cuff which you usually will have in examination rooms. There are three other cuffs. This is the large adult cuff, and this is used on the arms of patients who are obese or happen to have very large arms. This is the pediatric cuff, which is obviously used for children. And the fourth cuff is the thigh cuff, which is used for blood pressure determination in the lower extremity. Remember that blood pressure in the lower extremity is always higher by about 15 to 20 millimeters than in the upper extremities. This is applied to the thigh, and the stethoscope is placed in the popliteal fossa for evaluation. The first blood pressure is always assessed by palpation. Notice that the cuff is applied with the lower border about 1 inch above the antecubital fossa. One can place either thumbs or fingers on the brachial artery and inflate the cuff rapidly all the way up to about 240, 250, 260 millimeters of mercury, and then rapidly reduce the pressure. And at the point of palpation of the pressure, you will rapidly reduce the pressure in the cuff. We do this to rule out an auscultatory gap, which is very common. Now, after we've ascertained the peak systolic pressure, which was about 120 in Mr. Johnson's case, we will now do blood pressure by auscultation. And what we will do here is we will place the diaphragm of the stethoscope over the brachial artery and blow up the blood pressure cuff to about 15 or 20 millimeters higher than that which we palpated. So I'm going to blow up the blood pressure cuff now to about 140, and now very slowly I am going to reduce the pressure. The first sounds were heard at 120. The point of muffling was at 80, and the point of disappearance was at 75. So Mr. Johnson's blood pressure is 120 systolic, 80 is the point of muffling, and 75 is the point of extinction. It's very important to measure blood pressure to the nearest 5 millimeters of mercury, because if you were to say a blood pressure would be 127 over 79, this implies a false sense of accuracy of the determination. After blood pressure determination in the right arm, we're now going to do blood pressure by auscultation in the left arm. We're now going to proceed with blood pressure in the left upper extremity. We only have to do blood pressure by auscultation since we already know what the peak systolic pressure is. Mr. Johnson, may I just lift this up? Remember that the brachial artery is medial in the antecubital fossa, and the blood pressure cuff is applied just as we did for the right arm. Placing the mark of artery medial in the antecubital fossa. We will now proceed with blood pressure by auscultation. We will pump up the blood pressure cuff to about 20 millimeters higher than systolic and deflate the cuff slowly to record systolic blood pressure and diastolic blood pressure. The final assessment of blood pressure determination is orthostatic hypotension. What I'm going to ask you to do, Mr. Johnson, is when I tell you, I'd like you to sit up rapidly. Make sure that you are ready to determine blood pressure determination by having the set screw properly tightened. Mr. Johnson, I'm going to ask you to sit up in just a moment. Okay, are you ready? The set screw is tightened. And please sit up for me now. And again, blood pressure is determined by pumping the cuff up about 20 millimeters above systolic. And we now record the systolic and diastolic blood pressures. Okay. How do you feel, Mr. Johnson?
Fine.
Dizzy at all?
No.
Okay. If orthostatic hypotension were present, we would record a drop in the systolic blood pressure as well as usually an increase in the heart rate. This concludes our blood pressure determinations. We're now going to conclude our assessment of vital signs with the determination of heart rate and respirations. We determine heart rate first by the assessment of placing our hands on the radial artery, and we can do this bilaterally, as I'm demonstrating now. We will never use our thumbs for determination of the radial arterial pulse. We could also assess the brachial artery, and this can be assessed with either our thumbs or with the other fingers of our hand, and this can be assessed bilaterally as I'm demonstrating. We now want to assess respiratory rate, and one easy way of doing that is to turn your eyes up to the patient's chest and observe them while they're breathing. At the same time, you are watching your watch to determine the respiratory rate. This way, the patient is unaware that you're counting their respirations and they are not consciously changing the speed of their respirations. We're now going to begin the physical examination, and we usually begin the examination with the head. You'll notice that the examination proceeds in a very orderly fashion from the top to the bottom, and as we go through the evaluation of various parts of the body, we will first evaluate the patient by inspection, palpation, percussion, and then auscultation. We're going to first evaluate the cranial bones, the frontal, temporal, parietal, and occipital bones, evaluating whether or not there is any depression of any of these bones. We also want to evaluate hair. We want to evaluate the texture of the hair and whether or not the hair is firmly attached to the scalp. Our assessment will then continue with assessment of the lymph nodes, and there are a variety of lymph node chains in the head and neck. We will begin with evaluation of the occipital nodes, and the evaluation is done by a very gentle rolling motion of the fingers as they go over the head and neck. We then come to the posterior auricular nodes, down into the posterior triangle, up along the sternocleidomastoid for the superficial cervical nodes, down deep to the sternocleidomastoid for the deep cervical nodes, back up again to the anterior auricular nodes, and down along the jaw margin to the tonsillar nodes, the submaxillary nodes, the submental nodes, and then moving up back to the anterior auricular nodes. We're now going to continue with examination of the eyes. Mr. Johnson, we're going to start with assessment of your vision. And visual acuity is determined by either a wall-mounted Snellen chart or very commonly a pocket Snellen chart, as I have here. Mr. Johnson, would you take your right palm and place it over your right eye? And I'm going to hold this about 14 inches in front of Mr. Johnson's left eye. And could you read the smallest line possible?
Okay, 2, 4, 8, 3, 7, 6, 1.
Okay, you can bring the arm down, and if you put your palm of your left hand over your left eye, and would you now read the smallest line possible?
6, 9, 0, 2, 8, 3.
Okay, you can bring the arm down. It's important to test visual acuity either with a formal Snellen chart or anything that has any print on it. Very commonly what you might do is ask a person to read the smallest line possible on anything that you might have by your patient, and then use something else to test the vision in the other eye. What we're going to do now is assessment of the external eye structures. And Mr. Johnson, if you just look at my nose, and we will now bring down the lower lids, inspecting the tarsus, the lids, and the conjunctiva. We'll elevate the upper lids, looking at the lacrimal gland area in this area. And we're going to check also whether or not there is injection or dilatation of the blood vessels in the conjunctiva over the sclerae, noticing the size of the pupils and the shape of the pupils as well. We're now going to check visual fields by confrontation field testing. For this procedure, the patient is asked to remove his or her glasses, and the examiner must remove his or her glasses as well. For this procedure, you want to stand approximately 2 feet in front of the patient, and you'll ask the patient to close his or her right eye as you close your left eye. So, Mr. Johnson, could you close your right eye for me? And I'd like you to look at my nose. And I'm going to close my left eye and look at your nose also. The hands are placed slightly closer to me and in the nasal and temporal fields of the patient's left eye. Mr. Johnson, tell me how many fingers you see now.
3.
Okay. And how many fingers do you see now?
4.
Okay. Try again. How many fingers do you see now?
3.
Okay. What we're doing is assessing the nasal and temporal fields in the lower fields and in the superior fields. Please close your left eye. I'm going to close my right eye. Look at my nose. I'm looking at your nose. And Mr. Johnson, how many fingers do you see now?
3.
Okay. And how many fingers do you see now?
3.
Good. You can open your eye. Please make sure that when you do this procedure that the hands are closer to you, allowing the person to have the advantage of a larger field, and also that the palms are facing you as you hold up your fingers. We're now going to determine eye alignment and the pupillary responses to light. So David, what I'd like you to do is look in the distance, and I'm going to shine this pen light straight ahead, and I'm going to see where the light falls on individual corneas. We're looking first at the right and the left, and you'll notice that the light falls right directly in the center of the pupil, indicating that the eyes are straight. We're now going to continue on by using our pen light to check pupillary responses to light. And David, just continue to look in the distance as I shine this light from the side and shining it first on the left eye, looking for the direct and then consensual pupillary reflex, and then from the other side, the direct on the right and the consensual pupillary reflex on the left. We're now going to continue to test extraocular muscle function by means of evaluation of the cardinal positions of gaze. Because the rotational action of the obliques and vertical recti muscles cannot be easily assessed, the eye must be moved into 6 diagnostic cardinal positions of gaze that best isolate the vertical actions of these muscles in order to test their innervations. The oblique muscles are tested in adduction, That's with the eyes turned medial toward the nose, to maximize their vertical action. In contrast, the vertical recti muscles are tested in abduction, that's with the eyes turned laterally. In these positions, the superior rectus muscle acts now as a pure elevator, and the inferior rectus acts as a pure depressor. We're now going to test extraocular muscles. In order to do that, the examiner stands about 2 feet in front of the patient and stabilizes the patient's jaw. The other hand is placed with one finger in front of your nose, and the patient is asked to follow your finger as you go through the 6 cardinal positions of gaze. David, I'd like you to follow my finger. Okay, don't move your head, and follow it out here. You bring it out to about 15 or 18 inches from midline, all the way up here. And now we're testing the inferior oblique of David's right eye, the superior rectus of his left eye. As I bring the finger down, I notice the position of his eyes, being careful not to poke the eyes. We're now testing the superior oblique of his right eye and the inferior rectus of his left eye. Bring him back to mid-position. We're going to now switch hands. David, just follow my finger as we go all the way to the right, testing the medial and lateral recti, coming all the way up here, now testing the superior rectus of the right eye and the inferior oblique of the left eye. As we come inferiorly, we'll elevate the lids again to test the inferior rectus of the right eye and the superior oblique of the left eye. We're coming back to mid-position. David, I'd like you to watch my finger very carefully as I bring it in close. And we're now testing convergence of the eye. And we will then conclude this assessment in this position. One of the most important parts of the physical examination is the ophthalmoscopic examination, providing us with a wealth of information about the patient's health. This is the only non-invasive means of directly viewing vasculature in its native state. I'm going to demonstrate the use of the ophthalmoscope by using 3 different types of equipment. The first is the standard direct ophthalmoscope. A direct ophthalmoscope is an instrument which has a series of lenses which takes into account your refractive error as well as the refractive error of the patient. It's a light source which allows visualization of the cornea, the lens, the vitreous, and the retina. In order to use this instrument, you want to use the instrument held in your right hand using your right eye to examine the patient's right eye. In order to do this, you should remove your glasses and have the patient remove his or her glasses as well. If the person is wearing contact lenses, or if you're wearing contact lenses, they may certainly be left on. The light should be placed on, as I'm demonstrating here, and the patient is asked to look in the distance. You should stand approximately 15 to 20 degrees off midline and elevate the patient's upper lid as the ophthalmoscope is placed against your right eye to examine the patient's right eye. The first thing that you'll notice is the red reflex. If a red reflex is not seen, one has to be concerned that there may be some opacity, such as a cataract, in the lens. As you move closer to the patient, you will turn the lenses to focus deeper as one gets into the eye, past the lens, through the vitreous, and then into the retina. You must always be at eye level with the patient. First visualize superior nasal, inferior temporal, and superior temporal. And Mr. Johnson, please look at the light. And at that last second, the patient's macula has looked directly at the light, and one is looking then at the fovea of the macula. We repeat the same procedure on the left eye using your left eye and holding the equipment in your left hand. And again, I'm about 15 to 20 degrees off of midline. And keep looking in the distance. And as one gets closer to the patient, the diopter wheel focuses first as we go through the cornea, the lens, the vitreous, and now the retina. The optic disc is well visualized, as is the vasculature. Looking superior nasal, inferior temporal, superior temporal. And Mr. Johnson, look at the light, please. Thank you. This is the wall-mounted ophthalmoscope, and its operation is quite identical to the handheld unit. The only difference is that instead of the control on the handheld unit here, one has the on switch here. And the control of the intensity of the light is by this knob right here. In the newer wall-mounted unit, the brightness control is in fact in the handle. When one places it back into the holder, the instrument is turned off. The third instrument for direct ophthalmoscopy is the panoptic ophthalmoscope by Welsh Allyn. This provides a panoramic view of the fundus and provides a 5 times larger in diameter view than the standard direct ophthalmoscope. You can easily find the optic disc and the surrounding vessels, and it's easy to enter small non-dilated pupils. Whereas the standard direct ophthalmoscope provides only a 5-degree field of view, the panoptic provides a 25-degree field of view. This is actually 26% more magnification than the standard direct ophthalmoscope. The other advantage to the panoptic is that there is a greater working distance between the patient and the examiner, and I'd like to demonstrate it right now. The panoptic ophthalmoscope works with any of the standard 3.5 volt handles. This is the head, and this is the eye cup, and I will demonstrate its use in just a moment. First, one wants to use the continuous focusing wheel to focus on a distant subject, to get that subject in sharp focus. And then the equipment is used basically the same as your standard direct ophthalmoscope. A major difference is the eye cup. The eye cup, which aids in the stability of the unit, is applied directly to the patient's brow and is depressed about half of the length of the eye cup to visualize the red reflex. You should be able to see the optic disc, the physiologic cup in the disc, the arteries, and the veins. The cup is the portion of the disc that is central, lighter in color, and penetrated by the retinal vessels. The normal ratio of the cup to disc diameter varies from 0.1 to 0.5. The examiner should check the cup to disc ratio in both eyes for symmetry. The retinal vessels are evaluated as they arborize over the retina. The central retinal artery gives rise to 4 main branches that supply the superior and inferior aspects of the temporal and nasal quadrants of the optic fundus. And again, one will examine all of the quadrants as well as the macula in the standard fashion. A major advantage of this is that many individuals are one-eye dominant, and therefore may have trouble using their left eye to examine the left eye of the patient. With the panoptic, if you just turn this way, Mr. Johnson, and look straight in the distance, I can actually visualize Mr. Johnson's left retina by using my right eye, as I'm demonstrating now. In addition, of course, I could use the instrument in my left hand and examine the left retina as well. How are you feeling? Fine. Okay, we're now going to proceed to the examination of the ear. The first part of the examination of the ears is inspection of the external ear. One looks at the external ear and notices the helix, the antihelix, the tragus, the antitragus, and the external auditory canal. We want to palpate also. Mr. Johnson, does this hurt at all? Okay. Tenderness by pulling on the lobule or the antitragus will provide pain if the person is having an acute otitis externa. We're now going to evaluate auditory acuity, and there are basically two ways of doing that. One by whispering something in the patient's ear, and the second is a tuning fork test. Mr. Johnson, would you take your hand and place it in your external canal and tell me what I've said?
Train.
Okay, and if you now occlude the other canal?
Hospital.
Okay. We're now going to proceed with the evaluation of auditory acuity by a tuning fork test. Typically, one uses a 512 Hertz tuning fork. This happens to be a 128, which is certainly acceptable, but a 512 is generally the one which is used. There are two tuning fork tests, the Weber and the Rinne test. I'm going to demonstrate the Rinne test first. Strike the tuning fork by placing it into oscillation by striking the heel of your hand and then placing the vibrating tuning fork on the mastoid process of the patient. Mr. Johnson, do you hear or feel anything?
Yes.
Okay, tell me when you stop hearing it or feeling it.
It stops.
Okay, what about now?
I can hear it.
Okay, so air conduction is greater than bone conduction, and that's normal. AC greater than BC. The examination is conducted in the other ear as well. And do you hear or feel anything?
Mm-hmm.
Tell me when you stop hearing it.
Okay.
Okay, and what about now?
Yeah, I can hear it.
Okay, so air conduction is greater than bone conduction bilaterally. The second test is the Weber test, and one strikes the tuning fork and places it midline on the patient's forehead, and the patient is asked, do you hear or feel anything?
Yes.
Okay, tell me what you hear or feel.
Vibration.
Okay, where do you feel it?
Both sides of my head.
Does it feel equal, or is it in one place louder than another?
No, it feels equal.
We call that no lateralization, and that is the normal Weber test. I'm now going to demonstrate the otoscopic examination. The otoscopic head is put onto the handle, and the speculum, the largest diameter speculum, is used. In order to visualize the patient's tympanic membrane and external auditory canal in the right ear, the examiner places his left hand on the mastoid process and pulls up, out, and back, thereby straightening the external canal. The instrument may either be held this way to enter the canal or this way. Either way is acceptable. The most important part, though, is pulling up, out, and back to straighten the canal. In doing such, you will straighten the canal, place the speculum into the external auditory canal, and visualize the external canal and the tympanic membrane. You'll notice the malleus, the umbo, the light reflex pointing anteriorly, and perhaps other ossicles in the middle ear. To examine the left ear, the examiner uses his or her right hand to pull on the tragus and earlobe up, out, and back, and the otoscope can be entered into the external canal either as was demonstrated on the other ear or held in this manner, and the speculum is inserted as I'm demonstrating now. We're next going to inspect the nose and the nasal skeleton as well as the sinuses. Any tenderness here?
No.
Mr. Johnson?
Mm-mm.
Any tenderness here?
Nope.
Tenderness here?
No.
And what about here? Any tenderness here?
No.
This is evaluation of the frontal, maxillary, and ethmoid sinuses. Evaluation of the nose is done by having the person extend the neck and using a light source and elevating the tip of the nose, looking in the nares to see the position of the septum and if there's any discharge or separation of the septum. We're going to continue with examination of the mouth. Mr. Johnson, can you open your mouth for me? And say ah. Ah. We're now inspecting the oral pharynx. Stick out your tongue, please. We're looking at the position of the tongue to see if the tongue is in the center as it is stuck out and tongue back. And now we're looking at the teeth, the dental hygiene. We're looking at the buccal mucosa. We're looking at Stenson's duct. And again, say ah. And we're noticing the uvula and soft palate as it elevates. One can also do this procedure with a tongue depressor. And the way in which one does this is open your mouth, keep your tongue back in your mouth, and we are now pressing the tongue depressor on the anterior third or half of the tongue and scooping the tongue forward behind the front teeth. And now again say ah for visualization of the posterior pharynx. We can use the tongue depressor to move the buccal mucosa away from the gingiva to examine the gingiva as I'm demonstrating now. The next part of the examination is examination of the tongue. And for this examination, one would now put on gloves since this is an internal examination. We're now going to examine the tongue and the floor of the mouth, for which you should put on gloves. To examine the tongue, take a gauze pad and have the patient stick out his or her tongue. Hold the tongue gently and start at the back of the tongue and palpate along the lateral borders. Remember that most lingual carcinomas are on the lateral border of the tongue. Go all the way down to the tip of the tongue to evaluate if any masses are present. The examination of the floor of the mouth is done as follows. It is actually a bimanual palpation in which one finger is placed under the jaw and the other under the tongue, and you palpate for structures between the two fingers. But in order to do that, you want to make sure that you protect yourself from the person biting your finger. So that's done in the following manner. The examination finger palpating the bottom of the floor of the mouth, the second finger is placed under the jaw. And Mr. Johnson, open your mouth for me. The cheeks are pushed in to prevent him from biting down. And the second finger of the other hand is placed under the tongue. And you palpate, in this manner, the floor of the mouth. Examination of the floor of the mouth is an extremely important part of the physical examination, since oral cancers are very common. Those individuals who are predisposed to oral cancers are those smokers, tobacco users, and also patients who drink alcohol. And this concludes the examination of the head. We're going to continue now with examination of the neck. Mr. Johnson, we're now going to continue with the examination by examination of your neck. There are two parts of the examination of the neck with the patient in the seated position. The first is examination of the trachea, the position of the trachea. The second is the anterior and then posterior approach to thyroid evaluation. One wants to ascertain whether or not the trachea is midline, and one can place fingers like this on either side of the trachea and between the trachea and the sternocleidomastoid, and to determine whether or not the trachea is midline. The examination of the thyroid consists of an anterior approach as well as a posterior approach. The anterior approach is performed by taking your hand and moving the trachea to one side, thereby mounding the thyroid tissue on the other side. Remember that here's the larynx right here, that the thyroid tissue is in this area. And it's usually very soft and very small and quite difficult to evaluate. By mounding the tissue, you may be able to evaluate the thyroid gland better. So, chin down a little bit, Mr. Johnson. And I'm going to push the trachea to one side gently, thereby condensing this thyroid tissue and palpating the thyroid against the sternocleidomastoid. The same is done on the other side, and it can be done either with these fingers or with your thumb, moving toward the sternocleidomastoid. One now moves to behind the patient to evaluate the thyroid, known as the posterior approach. Place your hand midline, as I'm demonstrating here, and when I tell you, Mr. Johnson, I'd like you to swallow. What you'd like to do at this time is to swallow, and as the patient swallows, you're going to move in a rolling motion laterally toward the sternocleidomastoid. Okay. Now remember that patients can only swallow 1 or 2 times, so you only have 2 times to be able to do this. So Mr. Johnson, when I tell you I'd like you to swallow, okay? Mm-hmm. Swallow. And one more time. Okay. Would you mind, Mr. Johnson, just opening your robe a little bit off your shoulders? We're now going to evaluate supraclavicular lymph nodes. And from this position, good. Are you comfortable? Mm-hmm. Good. Here's the clavicles right here. You're going from this position, place your hands in the supraclavicular fossa, and when I tell you, I'd like you to take a nice big breath. Big breath. In, and out. And this is the technique for evaluating supraclavicular lymph nodes. If lymph nodes were present above the clavicle or at the clavicular level, the inhalation would move the lymph nodes up to become more evident over the clavicle. Of course, one of the important rules in physical examination is always keep your fingernails short, because especially on this examination, what you're doing is evaluating the supraclavicular fossa with the pads of your fingers, not jabbing the nails in, which could obviously be uncomfortable. Okay, we're now going to proceed with examination of the back. What I'd like you to do, Mr. Johnson, is to turn around this way so that we can evaluate your back. We're now proceeding with examination of the back. Obviously, one of the important parts of the examination, as you do any part of the examination, is first inspection of the skin, which is obviously done as you evaluate any particular part of the body. After you've evaluated and inspected the skin, we now want to proceed with examination of the back. First, we want to determine whether or not there's any tenderness along the vertebral column. Mr. Johnson, is there any tenderness here?
No.
Any tenderness here?
No.
Any tenderness here?
No.
Here?
No.
What about over here? Any tenderness here?
No.
Okay, what about here?
No.
Or here?
No.
Okay, any tenderness down here?
No.
And as I move down your spine, any tenderness here?
No.
Here?
No.
Down here?
No.
Or what about here?
No.
Notice I stopped over here. This was evaluation of costovertebral angle tenderness, CVA tenderness, which is seen in patients who have kidney disorders. Down over here, evaluation of the sacroiliac areas is very important to rule in or out sacroiliitis, which can be associated with many conditions. We're now going to evaluate posterior chest excursion. In order to do that, we place our hands and fanning the fingers out along the intercostal space, bringing our hands in this fashion, and then asking the patient to take a deep breath. And watch what happens to the fingers as the chest expands. Take a deep breath. Out. Again. The symmetric excursion of your hands is indicative of symmetric chest excursion. After we've done palpation of the back, we want to proceed with tactile fremitus. By placing the heel of your hand in an interspace and moving from side to side, you will evaluate the note, that which is determined from the patient's spoken voice. Mr. Johnson, can you say 99?
99.
99?
99.
99?
99.
And 99?
99.
99?
99.
99?
99.
99?
99.
99?
99.
99?
99.
99.
99.
What we're determining now is we're making sure that the tactile fremitus note is equal on each side. Please note that I went from one side to another to trying to determine whether symmetry was present or not present. It could either be done here to here, then here to here, or, as I did it, here to here, drop down, here to here, drop down, here to here. It must never be from here, here, and then on this side. Also, never examine a patient through a gown. The next part of the examination is percussion of the chest. Percussion is a very important technique which is done by applying one finger to the patient's skin and the other hand with a very sharp wrist motion taps the other finger. There are 4 basic types of percussion notes. First is timpani, second is resonance, third is dullness, and the fourth is flatness. Typically, over the lung fields, one hears resonance. Typically, over a cavity which contains a lot of air, one hears timpani. When one percusses over the liver, a large parenchymal mass, we hear generally dullness. And when one percusses over a large muscle mass, we hear generally flatness. Just as we did with the palpation, we go from side to side, evaluating whether or not symmetry is present. We always do this in interspaces as well, never on the ribs. And the final part of evaluation of the back is auscultation. And again, we do auscultation in about the same 6 or 7 different areas on the back using the diaphragm applied firmly to the chest wall. If the patient happens to have a very hairy back or a hairy chest, make sure that the diaphragm is applied firmly to the chest wall. Because otherwise, as they breathe, there are extra sounds which are heard, which might be mistaken for other pathological processes. It's generally nice to warm the stethoscope before you apply it to the patient's body because it, after all, is rather cold compared to the patient's skin temperature. Mr. Johnson, I'm going to ask you to open your mouth and take some nice big breaths in and out through your mouth. Okay? Big breath in. Again. 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 Good. And just breathe normally. Notice again that we went from side to side and that we listen in a complete respiratory cycle, inspiration and expiration, in each of the areas evaluated. We now want to evaluate the apices of the lungs of the upper lobe, and this is usually best done in the supraclavicular fossa and in the axilla. So I'm going to ask Mr. Johnson to just turn around a little bit this way. And keep your arms up. And say 99.
99.
99.
99.
99.
99.
99.
99.
99.
99.
99.
99.
And percussion. And keep your arms up. Good, you can put your arms down. Evaluation in the axilla and in the supraclavicular fossa are the areas which are best for evaluation of the upper lobes of the lung. I'm going to ask you to take a nice big breath in and out. Again, out. And can you just bring your arms up for me? And in and out. Again, out. Again. Again. Good. And breathe normally. We're now going to begin the evaluation of the anterior chest. And as we begin any new surface area of the body, we want to inspect the skin, evaluating it for any lesions that may be evident. We also want to inspect the configuration of the chest to see if there are any abnormalities that we will notice, such as the configuration of the sternum, whether it's out or pushed in, or if there are any other abnormalities related to rib structure. The first part of the examination of the chest is evaluation of the point of maximal impulse, the PMI, the cardiac apical impulse. And that is normally at the fifth intercostal space, midclavicular line. And we palpate that to evaluate whether or not it is present. If it's not palpable in this position, you might have the person lean forward a little bit to see if it is evident. If it is laterally displaced, one has some information and some evidence that there may be actually left ventricular enlargement or hypertrophy, thickening of the wall of the heart. We now are going to proceed in evaluation of the examination of the heart and lungs, and most of the examination of the lungs I do lying flat. It's not wrong to do it sitting up, but I'm going to demonstrate the way I do this examination, and that's usually with the patient lying flat. So we're first going to evaluate in the aortic area by palpation, and the aortic area is the second intercostal space to the right of the sternum. The pulmonic area, the second intercostal space to the left of the sternum. Down along the sternal border, to the left lower sternal border, the tricuspid area, and moving over to the cardiac apex, the mitral area, palpating to see if there are any vibrations which one might feel. These are known as cardiac thrills, and they're generally indicative of turbulent flow across those valves. And the auscultation of the heart proceeds by evaluating the 4 cardiac areas just demonstrated. Warm the stethoscope, listen first in the aortic area, the pulmonic area, the third intercostal space left of the sternal border, known as Erb's point, the tricuspid area, the left lower sternal border, and the mitral area, the fifth intercostal space, midclavicular line. One moves back with the diaphragm to the aortic area and the pulmonic area, known as the base, and as the person leans forward, one listens for the high-pitched diastolic murmur of aortic insufficiency. Sit back. You may have a stethoscope which has a convertible diaphragm. If that's the case, very hard pressure on the skin allows that diaphragm to be an actual diaphragm. Whereas if you press lightly on the skin, that diaphragm functions as a bell. What I'm going to do is I'm going to ask you to lie down as we continue the examination. Are you comfortable, or would you like to put your gown back on?
No, I'm fine.
Okay, good. If you lie back, I'm just going to pull the leg extender to make you a little more comfortable, and we'll proceed with the examination in this position. Comfortable? Mm-hmm. We're now going to proceed with examination of the chest and lungs. We haven't examined the lungs yet, so we'll begin with that right now. We first want to do the anterior chest, again, just as we did with the posterior chest, first by palpation, followed by percussion, and then auscultation. Say 99.
99.
99.
99.
99.
99.
99.
99.
99.
99.
99.
99.
99,
99,
and 99.
99.
One uses the same technique, applying the heel of your hand in an interspace. Obviously, we have the heart in this area, and we do not evaluate over the heart because this would be an area in which tactile firmness would be different than the area on the other side. Percussion is done by the same technique that we did in the back. Mr. Johnson, would you just turn your head off to the side and we evaluate the percussion note as well. There are some people who believe that percussion of the cardiac border is a technique worth doing. It generally is a technique of low sensitivity and specificity, and I feel that it's not a technique that is very useful to determine cardiomegaly. And finally, the last part is auscultation of the lungs. And we will auscultate in the same areas that we were doing our percussion and palpation. Mr. Johnson, just turn your head to the side and open your mouth and take a nice big breath in, out, again, 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 and again. And now that completes the examination of the lungs. We're going to continue with examination of the heart. And again, we do the same procedure as we did when the patient was sitting, using the pads of our fingers in the aortic area, in the pulmonic area, down along the left sternal border to the tricuspid area, over to the mitral area, palpating very lightly with our pads of our fingers for cardiac thrills. We'll then take the heel of our hand and place it on the sternal border to see if there's any impulse that we can palpate. Patients who have right ventricular enlargement may have something called a right ventricular lift or heave, and the hand may be actually lifted off the chest wall. We can do the same technique over here at the fifth intercostal space, midclavicular line, and if we found that same impulse, this would be suggestive of left ventricular enlargement or hypertrophy. Finally, we're going to do auscultation of the heart in a lying position as well in the left lateral decubitus position, which are the two other standard positions for cardiac auscultation. We will listen again in the aortic, pulmonic, Erb's point, left lower sternal border, tricuspid, and the mitral area. Auscultation of the pulmonic area with the patient lying is the best position to evaluate splitting of the second heart sound. The final standard cardiac position is evaluation of the mitral area using the bell with the patient in the left lateral decubitus position. Mr. Johnson, can you just move your body closer to me? Just move over straight this way and turn over on your left side. That's fine. And with the bell, listening in the mitral area for the low-pitched diastolic murmur of mitral stenosis. And you can turn back. Comfortable? Application of the bell to the chest wall should be very, very gently, because if you press too hard with the bell on the chest wall, the skin becomes a diaphragm and you lose the ability to hear the low-pitched sounds. Remember that the diaphragm is best used for high-pitched and medium-pitched sounds. The bell is used for low-pitched sounds. This completes examination of the anterior chest, and we're now going to move on to examination of the abdomen. Now that the patient has changed posture, we want to start at the top of the body and work our way down, deciding whether or not every part of the body has been examined appropriately. I actually divide the body into the head, the neck, the chest, the abdomen, the genitalia, the legs, and then the neurological and musculoskeletal examinations. So let's start at the top, and have we forgotten to do any part of the examination of the head? And we actually have completed all of it. As we move down to the examination of the neck, there are two very important parts of the exam which we have not yet done. One is evaluation of the carotid. And before one palpates the carotid, it is absolutely mandatory that you auscultate the carotid first to make sure that there are no carotid bruits present. One just takes the diaphragm of the stethoscope and places it over the carotid and evaluates whether or not bruits are present. If no bruits are present, you can then palpate the carotid. The carotid artery is best palpated by placing your hand on the trachea and sliding it between the trachea and the sternocleidomastoid, as I'm demonstrating now, and going straight back in this position, making sure that you palpate only one carotid at a time. After you've done that, you can palpate the other carotid as I'm demonstrating now. One then wants to evaluate neck veins, and an observation that should have been made when the patient was sitting up was whether or not the neck veins were distended to the angle of the jaw. Clearly, neck veins as a manometer are an indirect manometer of left ventricular end diastolic pressure and a direct manometer of right ventricular end diastolic pressure. So if the neck veins are very distended sitting up, one can be pretty much assured that one is dealing with a patient who has left ventricular end diastolic pressure elevation. One also wants to evaluate the waveforms, the A, C, and V waveforms of the jugular pulse. And one looks at the jugular pulse in a way which is very easy to enlarge and exaggerate the pulse motion, is to take a penlight and to place your hand on the sternum and to shine a light tangentially to the jugular pulse. And you are then looking for ACV waves. You'll remember that the A wave is related to atrial contraction. The X descent is the relaxation of the atria. The C wave is closure of the tricuspid valve. The X prime descent, which is descent to the base of the heart. And the V wave is atrial filling, which culminates with the Y descent, which is when the tricuspid valve opens. Any abnormality of the valves or compliance of the valves or of the ventricle will give you an abnormality of these particular waveforms. So they're really very important to evaluate, and they're done in this manner. We want to begin the examination of the abdomen, and the first part of that examination is to inspect the contour of the abdomen as well as inspecting the skin of the abdomen. The next part of the examination is to inspect for hernias. The patient should be disrobed, and you should have visibility of the person's abdomen from approximately this area down to the symphysis pubis. Are you comfortable? Would you like to have your gown on, Mr. Johnson?
I'm fine.
Comfortable? Okay. We want to have exposure of the patient's femoral area, and we can do that by placing the drape in this fashion. And we will then ask the patient to cough. Mr. Johnson, would you turn your head to the other side and cough for me? And we want to observe, cough, we want to observe this part of the abdomen as well as this part of the abdomen. This part of the abdomen for umbilical or incisional hernias. And then, of course, we want to look in this area, in the inguinal area, and in the femoral area to see if there are any pulsations when the person coughs. Cough again. Again. We can then place our hands in the inguinal area and cough, and in the femoral area and cough again. Okay. At this point, we can return the sheet to preserve the modesty of the patient. And the first part of the examination of the abdomen is auscultation. We auscultate before we palpate the abdomen because if bowel sounds were absent, we might artificially stimulate bowel sounds by palpation. So one places the stethoscope anywhere in the abdomen and listens for 15 to 20 seconds to determine whether or not bowel sounds are present. We can then place the stethoscope about 1 inch above the umbilicus and about 1 inch lateral to the umbilicus, evaluating for renal artery bruits. There are two types of palpation. One is light palpation, the other is deep palpation. Light palpation is used to ascertain whether or not the patient is having any tenderness in the abdomen. If a person is having any tenderness in the abdomen, you evaluate that area last. Are you having any tenderness in your abdomen, Mr. Johnson?
No.
Okay. The technique for palpation is basically to place your hand firmly on the abdomen and with your fingers in this position, press down very lightly while you're observing the patient's face. It's critically important to evaluate the patient while you're watching his or her face to see if the patient winces, even though you are asking them whether there's any tenderness. So by placing my hand gently on the abdomen, I'm going to look at the patient's face and ask, any tenderness here?
No.
What about over here?
No.
Any tenderness here?
No.
Over here?
Nope.
Here?
Nope.
Any tenderness here?
Mm-mm.
And over here?
No.
And finally here?
No.
You then proceed with deep palpation. Deep palpation uses one hand applied to the skin and the other hand firmly presses down and provides the pressure. The hand at the bottom is the hand which is palpating for masses. The hand at the top is the hand that is pressing down and using the pressure to push the lower hand down. And you use a rolling motion, again looking at the patient's face. You've already ascertained that there is no tenderness present in Mr. Johnson's case, but you then use a rolling motion as you roll over the descending colon. And you can ask, are you having any tenderness?
No.
Coming over here across the transverse colon, any tenderness?
No.
What about over here? I know this may feel a little uncomfortable, but if there's any pain, please let me know.
No.
Any tenderness here?
No.
As you're rolling over now the ascending colon, and finally down toward where the cecum exists. After you've done that, we want to go on to special palpation. Special palpation is done of the liver and of the spleen. And there are several techniques which one can use. We can start low in the abdomen and start in this fashion, going up toward the costal margin as the patient takes a deep breath. Take a big breath and out. Again. Out. Again. Out. We could also place our left hand under the right costal margin and do the same technique as was just demonstrated. We could also do something called the hooking technique, which is placing your hands in this part of the abdomen, standing in this position, and actually trying to hook the liver edge as the patient takes a deep breath. Take a big breath. And out. Again. And out. All of these techniques are useful to determine the lower edge of the liver. The upper edge of the liver is done by percussion of the chest, from where the percussion note goes from resonant over lung tissue to dull over the liver parenchyma. Resonant, 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 dull. So this is the upper border of the liver. This was the lower. One usually measures the span of the liver in the midclavicular line, and normally about 10 centimeters or 12 centimeters is the normal span for a liver. It's normal.
Good.
Okay. We can go on to evaluation of the spleen, and again we start low in the abdomen, starting here and moving up, and take a big breath, and out, again, and out, again, and out. We might place our hand over the left costal margin to support it and to palpate the spleen in this fashion. Normally the spleen is not palpable, whereas the lower edge of the liver may very well be palpable in many individuals. All four quadrants of the abdomen are also evaluated by percussion. If a person is very well developed and has a very muscular abdominal wall, if the person has ascites, which is fluid in the abdomen, or if the person is just frankly obese, all of these exams obviously are a lot more difficult to evaluate. We're now going to move on to evaluation of the pulses of the lower extremity. First, the femoral pulses, evaluating also the timing of the femoral pulse with the radial pulse. These two pulses peak at the same time. And in a patient who has coarctation of the aorta, one will have a delay in the femoral pulses. Remember that coarctation of the aorta is a very important cause of systemic hypertension of the upper extremity and actually hypotension in the lower extremity. Any patient who, especially if the person is young, who has hypertension should be evaluated for blood pressure in the upper extremities, and as we talked earlier, should be evaluated for blood pressure in the lower extremities. And lower pressure is always abnormal. Lower pressure in the lower extremity compared to the upper extremity in association with a delay in femoral pulses is very strongly suggestive of coarctation of the aorta. We're now going to proceed with examination of the peripheral pulses before we go on to examination of the genitalia. We're now going to proceed in the evaluation of the peripheral pulses of the lower extremities. And the first pulse we will evaluate is the popliteal. The popliteal is one of the more difficult pulses to feel, even though the pulse itself is relatively large and relatively strong. The manner in which you evaluate the popliteal is by placing your hands on the patella and placing your other fingers in the popliteal fossa and trying to sandwich the popliteal pulse between your fingers and the bone. You may want to elevate the leg slightly, but do not have the patient elevate his or her leg. After one pulse, one goes to the other side and evaluates the other leg, as I'm demonstrating now. We're now going to move on to the distal pulses, the posterior tibial and the dorsalis pedis. The two distal pulses which we routinely evaluate are the posterior tibial and the dorsalis pedis. The posterior tibial runs along the leg down here and courses around the medial malleolus. To evaluate the posterior tibial artery, you place your hand on the artery and push it up toward the medial malleolus, palpating the artery against the bony structure. You can do this on both sides, as I'm demonstrating now. The dorsalis pedis artery runs along hallucis longus, right here. And you can palpate it by placing your fingers, never your thumbs, here and on this side, and they can be palpated simultaneously. And that concludes the evaluation of the peripheral vascular system. The conclusion of the complete physical examinations consists of the neurologic examination and the screening musculoskeletal examination. The neurologic examination consists of the mental status exam, cranial nerves, sensory function, motor function, evaluation of reflexes, and cerebellar function. The mental status examination is frequently part of the history. The mental status examination consists of level of consciousness, speech, orientation to person, time, and place, knowledge of current events, judgment, abstraction, vocabulary, emotional responses, memory, calculation ability, object recognition, and praxis, the ability to perform motor action. We're now going to begin the assessment of cranial nerves, and many of the cranial nerves we've already assessed, but those which we've not, we're going to do at this time. Cranial nerve 1, olfaction, is usually never assessed. Cranial nerve 2, we've assessed. Cranial nerve 3, we've assessed. Cranial nerve 4, we've already assessed. But cranial nerve 5, the trigeminal, we have not. There are three components to the trigeminal nerve: the ophthalmic, the maxillary, and the mandibular. So let's assess the sensory function first. Mr. Johnson, I'm going to take this gauze pad and I'm going to touch you someplace on your face with it. I'd like you to close your eyes and tell me, where did I touch you?
The right side of my forehead.
And now?
The left side of my forehead.
Did it feel similar or dissimilar?
It felt the same.
Okay, keep your eyes closed again. I'm going to touch you again on your face. Where did I touch you now?
Left cheek.
And now?
Right cheek.
And how did that feel?
Felt the same.
Okay, and keep your eyes closed. And now?
On my chin, the right side.
And now?
And the left side, my chin.
How did that feel? Similar or dissimilar?
Felt similar.
Okay, you can open your eyes now. We're now going to check the motor function, namely the contraction of the masseter muscles. Can you bite down real hard? And we're checking for symmetry of the masseter. Okay, and you can relax. We're now going to check the corneal reflex, which you'll remember has the afferent limb from 5, the trigeminal, and the efferent limb from 7, the facial. In order to test the corneal reflex, you'll take an applicator stick and pull off a wisp of cotton from the end of the cotton tip and twirl it into a very, very thin wisp, as I'm demonstrating now. Mr. Johnson, what I'd like you to do is just look in the distance, right over here, and I'm going to very quickly touch the cornea, and we're looking for a very rapid blink. So if you just look straight in the distance, and that was a very brisk corneal reflex. We will do the same on the other side. If you just look in the distance, straight, straight. That was a lash reflex. That was not a corneal, but that was a corneal. The 6th cranial nerve we've already evaluated when we were evaluating extraocular muscles, but now we're going to continue with examination of the 7th, the facial nerve. What I'd like you to do is to smile for me. Give me a big smile. Big smile. Great. We're noticing whether or not symmetry is present. We're also noticing the nasolabial folds. Good. Can you frown for me? Okay. Can you wrinkle your forehead? And we're looking for symmetry here as well. Good. Can you puff out your cheeks like this? Good. Don't let me push them in. Good. And relax. And finally, I'd like you to close your eyes real tight and don't let me open them. Fine. Okay, you can open them now. That's the 7th cranial nerve. 8th we've evaluated. The 9th and 10th, glossal pharyngeal and vagus, we've evaluated when we had him say ah, and we performed the gag reflex. The 11th, the spinal accessory, we're going to assess right now. Can you push up real tight, real hard? Good. And relax. And can you push against my hand as we evaluate the strength of the sternocleidomastoid and relax? Evaluate the sternocleidomastoid on this side. And relax. And the 12th cranial nerve, the hypoglossal, we evaluated when he stuck out his tongue. So this concludes the evaluation of the cranial nerves. We're now going to continue on with sensory function. The sensory examination consists of taking a gauze pad and having the patient close his eyes as you touch the distal upper extremities and then the distal lower extremities. So Mr. Johnson, just close your eyes for me, please, and tell me, where did I touch you?
My right hand.
Okay. And now?
My left hand.
Okay. Did that feel similar or dissimilar?
It felt similar.
Okay. And keep your eyes closed. Do you feel this?
Yes.
Okay. And do you feel this?
Yes.
Similar or dissimilar?
Similar.
If you determined an abnormality, you would then work your way proximal on the extremity to determine the sensory level. Vibration sense, we're going to do basically the same technique with the distal extremity upper and then lower. Strike the tuning fork and then, very importantly, place your finger under the finger of the patient being examined. If you're able to palpate the vibration, the patient certainly should. Close your eyes, please. And do you feel anything?
I feel a vibration.
Okay. And what about now?
Yeah, I still feel it.
Okay. What about now?
Yeah, I feel it stronger now.
A very useful test to check the reliability of the patient is to strike the tuning fork like this, but then to dampen it by keeping it against your hand, stopping the oscillation, and then attempting to do the test again. And this way you will be able to test the reliability of the patient's response. We'll do this also in the lower extremities. Close your eyes, please. And now, feel that?
Yep.
And do you feel that?
Yeah.
Does that feel similar or dissimilar?
Similar.
Okay, you can open your eyes. The final test for sensory function is to test sharp and dullness with a safety pin. Always dispose of the pin after you've used it to avoid transmission of the hepatitis and AIDS viruses. So I'm just going to open this pin, Mr. Johnson. I'd like you to close your eyes for me. And this is dull, and this is sharp. Okay. What's this?
Dull.
Okay. What's this?
Sharp.
Okay. What's this?
Sharp. Dull.
Okay. Keep your eyes closed. What's this?
Sharp. Dull.
And what's that?
Dull.
And what's this?
Sharp.
Okay. Keep your eyes closed. This is sharp. And this is dull.
Okay.
Okay. What's this?
Dull. Sharp.
Okay. And this is sharp. And this is dull. What's this?
Dull.
Okay. And this.
Dull.
And this.
Sharp.
Okay. Does it feel about the same?
Yep.
Okay. Now we're going to dispose of the pin. We're now going to assess position sense. Mr. Johnson, would you close your eyes for me? I'm going to hold the distal digit of the finger and the sides of the finger and tell me this is up, this is down. What's this?
Up.
Okay. And this is up, this is down. What's this?
Down.
We would then repeat the same procedure on the other hand and the lower extremities. We've just completed our assessment of sensory function, and now we're going to go on to our assessment of reflexes. There are 3 reflexes in the upper extremity and 2 in the lower. The first in the upper extremity is the biceps tendon reflex. What one does is to support the patient's arm and to place your thumb on the biceps tendon. You then take your reflex hammer and briskly strike the tip of your thumbnail. The response that we're looking for is a rapid contraction of the biceps muscle. The second reflex is the triceps reflex. We can support the arm, and in this example, we strike the triceps tendon directly, avoiding the ulnar nerve. The response we're looking for here is a rapid contraction of the triceps muscle. The third reflex in the upper extremity is the brachioradialis reflex. The arm is placed in this position, and the brachioradialis tendon is struck here, and the response we're looking for is supination of the hand. All 3 of these reflexes are then repeated on the other side. Now we're going to go down to the reflexes of the lower extremity. The patellar reflex is evaluated by placing your hand on the person's thigh, and close your eyes please, Mr. Johnson, and striking the tendon briskly. One more time. We would repeat this on the other side as well. We're now going to do the Achilles reflex. One method of assessing the Achilles reflex is to flex the hip, knee, and ankle, as I'm doing now, and to briskly strike the Achilles tendon. The response we're looking for is plantar flexion of the foot. While we're in this area, we can also attempt to elicit a Babinski reflex. Remember that a Babinski reflex is an abnormal reflex. We place the tip of an applicator stick at the heel of the foot and bring it on the lateral margin, coming to the base of the toes, running to the base of the large toe, as shown. The normal response is plantar flexion. The abnormal response is dorsiflexion and a fanning of the toes. This response, an abnormal reflex, is seen in pyramidal tract diseases. And this concludes our assessment of reflexes. We're now going to continue with the assessment of motor function. We're now going to assess motor function and a screening musculoskeletal examination in the upper extremities. Mr. Johnson, I'd like you to trap my hand, bring your chin down, and press and relax, and do it back here. Press and relax. Trap my hand over here and relax. Trap here and relax. Push forward and relax. Push back and relax. You bring your arms up like this and push and relax and push down and relax. Make a fist for me. Don't let me open them and relax. And don't let me push your wrists in and relax. Good. You can put your arms down here. We're now going to assess motor function in the lower extremities. Push up and relax and push down and relax. Push forward, relax, push back, relax, push up, relax, and push down and relax. One test for cerebellar function is the finger-to-nose test. I'm going to place my finger here, and if you raise your right finger and touch my finger and touch your nose. Touch my finger, touch your nose. Touch my finger, touch your nose, close your eyes, touch my finger, touch your nose, touch my finger, touch your nose, and you can open your eyes. An important assessment of cerebellar function is the Romberg test. Would you put your feet together for me? And just bring your arms up like this and close your eyes, and I'm going to let your hands go. And just stand like this with your fingers open. Fine. You can open your eyes, put your arms down. We're now going to assess gait. The final part of the neurologic examination is assessment of gait. Would you walk toward me and stop right there and turn around and walk on your toes? And turn around and walk on your heels to me. And stop right there and turn around one foot in front of the other, tandem walking like you're walking a straight line. Fine, and you can stop right there. And this concludes the complete examination of the man. We're now going to continue with examination of the female breast and the pelvic examination. We've just concluded the complete examination of the man, and we're now going to do the breast and pelvic examinations. Ms. Woods, hi, I'm Dr. Swartz.
Hi.
How are you today?
I'm good, thank you.
Good. How are you feeling?
Just fine.
Good. This is Jean, who's going to be working with us today. We're going to be doing a pelvic exam, so would you just make sure that all the equipment is in order?
Will do.
Okay, thank you. How are you feeling today?
Good.
Good. Are you having any problems with any breast discharge or breast tenderness or
No.
breast masses?
No.
Any problem with discharge from your vagina?
No.
Okay. Okay, well, I guess we're going to then begin the breast examination.
Okay.
Okay? Would you just allow your gown to drop down to your waist? The first part of the breast examination is inspection of the breast. We inspect the breasts for asymmetry. One stands in front of the patient and observes the contour of the breast and the position of the nipples, and whether or not there is any dimpling of any breast tissue. Dimpling of breast tissue is very commonly consistent with an underlying tumor. In order to exaggerate any possible asymmetry, various pectoral maneuvers are performed.
Great.
What I'd like you to do, Miss Woods, is if you place your hands on your waist like this and press real hard. Fine. As you can notice, the pectoral muscles are tensed at this time, and if there were an underlying tumor, there may be a change in the contour of the breast. You can release your hands. Could you take your hands like this and pull real hard? Again, another maneuver which tenses the pectoral muscles. Fine. And finally, could you raise your hands above your head like this? And this maneuver allows the breast tissue to be spread over more of the chest wall. If there were some underlying mass, it may be more evident in this position. Good, you can put your hands down. Before we proceed with palpation of the breast, we're going to perform an axillary examination. Axillary examinations are very important. Performance of the axillary examination is done by placing your hands low in the axilla and with slow rolling motions, very similar to that which we did with the examination of the lymph nodes, the head and neck. We go up in the axilla, first along the chest wall, against the anterior musculature, the posterior musculature, And as we go high in the axilla, making careful that we're not pulling any hair or not using anything other than the pads of our fingers, we'll bring the arm in to reach high in the axilla as being demonstrated now. After we perform the axillary exam on one side, we'll do it on the other. We start low in the axilla, and again the slow rolling motion using the pads of your fingers against the anterior musculature, the posterior musculature, and as we go high in the axilla, the arm is brought in to allow us to reach the apex of the axilla. And this concludes the axillary examination. We're now about to begin palpation of the breast. Breast palpation is always performed with the patient in a lying position. We also request that the woman place her hand above her head. Can you just place your hand above your head like this, Ms. Woods? What this maneuver does is to spread the breast tissue more evenly over the chest wall, allowing one to palpate the breast tissue. This is a particularly important maneuver to do in large-breasted women. It's frequently asked how much pressure should be used during breast palpation. The answer is that it's really dependent upon the density and the size of the woman's breast. In general, we usually recommend about 3 levels of pressure. We also recommend placing a support under the scapula on the side of which the breast is being palpated. There are 2 methods of breast palpation. The first is known as concentric circles. What we do in this procedure is we start at the areola and with varying degrees of pressure, we will circle the areola as is being demonstrated right now. After we've gone from one area, we will proceed going out further. In this manner. And what we are palpating for are any nodularities of the breast tissue. If one detects any nodularity, it's appropriate to ask the patient, had she ever noticed it? It's also very important to ask all of your patients whether or not they do breast self-examinations, and if they don't, it's incumbent upon you to actually teach them how to do that. Remember that in doing the breast examination, the tail of the breast extends out to the axilla from the upper outer quadrant right over here. We can do this with 3 levels of pressure, as I've just indicated. The second method of palpation of the breast is known as spokes of the wheel. And if one imagines the center of the wheel at the nipple, we will then start at the nipple and go first at the 3 o'clock, back, 4 o'clock, 5 o'clock, 6 o'clock, and all the way around the breast, palpating first soft and then finally firmly against the chest wall. And we would continue going around the entire breast, after which we would proceed with the same procedures on the other breast. It's also important to palpate the nipple, and you could take your fingers and rock the nipple, as I'm demonstrating here, because very commonly there could be tumor right underneath the nipple, which you may actually miss by just the other methods of breast palpation. We also would like to see if there is any discharge which can be expressed from the nipple. And there are 2 ways of doing that. We could either ask the patient to see if she could express any discharge. Would you see if you could express any discharge, Ms. Woods? And what Ms. Woods was doing was to milk the ducts to see if there was any discharge. Alternately, the examiner could place his or her hands on the breast and slowly and gently, but firmly, press on the breast tissue, trying to express any fluid from the nipple. You consolidate the breast tissue to see if there's any dimpling as a result of neoplastic processes within the breast. You do that by taking your hand and mounding the breast tissue as I'm demonstrating now. This would be done in the other breast as well. And this concludes the breast examination, and we're now going to begin the pelvic exam.